Good morning, ladies and gentlemen. Good morning, friends. Good morning, dear colleagues. It's wonderful. It's exciting for me to have you all here at Harvard Business School for our second annual conference of the International Consortium for Health Outcome Measurement, for Ichom. I would like to welcome all of you on behalf of our co-founders, of Michael Porter, professor at the Harvard Business School, of the Boston Consulting Group, and of the Karolinska Institute, and of course, of my dear colleagues from Ichom. It's amazing to see how the Ichom family has grown over time. Last year, when we had our first conference, the setting could have been more different and, to be honest, more challenging. It was exactly the day after Hurricane Sandy has hit the East Coast. And people were upset, and the country was in a bad shape by then. And actually, a car had crashed in the room next to our meeting room in the hotel, which made it not easier. So basically, half of the participants of the launch meeting were captured in different airports around the world. And we were begging for them to find weird flight constellations to come to Boston. So this year is easier. Thanks for coming. A year ago, Ichom was actually not even existing. It was a piece of paper with 4 signatures on it. A year ago, Ichom didn't even have staff, not even an office. Ichom was not more than a very ambitious plan. A big idea. We wanted to transform healthcare because we believe that we all work in healthcare in a substantially flawed system. We work in a system where physicians and care teams are working hard their whole life to improve the patient care, but they never receive information and data how good they really are. And so they follow traditions and beliefs, and they sometimes never improve. And there are patients who are begging for information about treatment options, where to go, where is the doctor that can help me best. And they don't have access to this kind of information. And at the end, we have health plans who pay for all that, based on case numbers, based on procedure intensity. We all agree that this is not a sustainable system, that this is something we have to change. And we have to change it by redefining success in healthcare. We believe that we need to systematically measure outcomes, the results that matter to patients. We believe that we have to bring this information back to the community, to the physicians themselves, that they are able to learn, to improve, and to the patient that they have a chance to find the right treatment. We came here today to discuss about outcome measurement. And in the first part this morning, we will reflect on why are outcomes so important. After that, we want to share with you what Ichom has done so far. We have created the first outcome standards for important medical condition in mankind's history, together with great working groups and fantastic working group leaders, and we want to share with you these results. And in the afternoon, we want to discuss how we can transform healthcare based on this kind of information. But before we get started, I really want to thank everyone for coming, particularly our dear speakers. They all came without charging anything, not even a flight. They came because they believe in our mission, and they have something to share with you. Thank you very much for coming. Thank you. But before we go into the details, I want to share a little bit what drives the Ichom team. Why do we believe we have to do that? And this has something to do with variation. The ones of you who have been here earlier when it was still a little bit quiet in the room, they might have recognized that there was music playing. And the ones of you who love classical music have recognized that it was the Goldberg Variations by Johann Sebastian Bach. Beautiful piece written by Bach for one of his students. His name was Goldberg, and who played this piece during nights for hours for Count Kaiserling, who was suffering of insomnia. A variation can be a beautiful thing in music. You know, you have a kind of a basic theme, and you play through, and you play it through in different ways, you alterate, and this is a wonderful way to get amused. So we love variations in music. And variations can enrich all our lives. And I can tell you, by moving to Cambridge, one of the most diverse places in the world, I and my whole family enjoy so much the variations in human beings we have around us. Variations in the nature can be very beautiful, particularly when you see the foliage in the Indian summer like we did a couple of weeks ago. Variations can sometimes be unexpectedly spicy. I could tell you something about entering as a German a random Indian restaurant in Cambridge and asking for a very hot meal, assuming that there is a standard on very hot in the world, which is not true. Variations can arouse your curiosity, particularly if you see a team of civilized persons running around with wonderful moustaches, like the Ichom team does. We do that in solidarity with Movember, one of our dear sponsors who want to use the moustache, to make us aware of men's health problems. But variation can also be challenging, can be very problematic, particularly if we see variation in access to things we believe that they should be distributed in a very fair way. This is showing you how many places in the world are suffering from not having the right access to fresh water. And of course, variation is a topic in healthcare. Look at these figures. A twofold variation in 30-day mortality rates from heart attacks in US hospitals. Difference between the good ones and the bad ones. A threefold cost variation between hospitals in the US and India. And by the way, after correcting for income and salary differences, simply driven by different processes. And in cancer care, it's a ninefold difference by having better results in India. A fourfold variation in bypass surgery mortality in the UK. Ninefold variation in complication rates from radical prostatectomies in the Netherlands. 18-fold variation in reoperation rates after hip surgery in my country. And we do a lot of this stuff, I tell you. 20-fold variation in mortality after colon cancer surgery in Sweden. 36 variation in capsule complications after cataract surgery in Sweden. And my personal favorite, 65-fold variation in arthroscopy rates between bigger and smaller cities in Germany. This is a shocking and unbearable situation. And the first shocking thing we have to realize is it's everywhere. And if I haven't mentioned your country, the simple reason is because you don't have data. Secondly, it took us a year to put these kind of data together, a year. Variations are hidden. They are hard to find. You need to be specialized. You need to grab. You have to go into registries and stuff like that. They have a tremendous impact on individuals' life. They drive enormous costs. And for us, it's simply unbearable for the future of healthcare. So we believe we have to reduce variation. And I want to share with you one example where this has happened. You know, I'm trained as a human geneticist, and one of the first medical disorders you learn in human genetics is cystic fibrosis. Cystic fibrosis is a very severe disease, as most of you know. It leads to a clotting of mucus in newborns and children, and this mucus is finally destroying the airways and the digestive system. So children with cystic fibrosis typically suffer from malnutrition and from respiratory problems. They develop pneumonias and they die very early. And they have, for a biochemical reason, a very salty sweat. This is a picture and a saying from the 17th century in Germany, which simply says, if you kiss your baby and it tastes salty, that baby will die. It's a very, very sad and touching picture. You do the most intimate thing you can do as a mother. You kiss your kid, and that tells you it will die. And actually, that was not only the true reality in the 17th century. Until the 50s, the late 50s, of the last century, people had children with cystic fibrosis had a life expectancy of 5 years. I want to share with you a journey of improvement that is so exciting for us. In the year 1957, when the average survival of kids with cystic fibrosis was 5 years, there was a gentleman with a cystic fibrosis program in the US who reported, my average survival rate in my center is 20 years. He was an outlier. People didn't believe him. They said, well, you know, this is not cystic fibrosis. It's something different. I don't believe the data, whatever. But the Cystic Fibrosis Foundation, a patient advocacy group that was founded at the same time, they got interested into that and say, well, it's interesting. He's reporting these data. He's even claiming that there is no child that has been died before it was 10. So they did something really exciting. They took $10,000 and they gave it to a physician they trusted, to Warren Warwick in Minneapolis, and said, Warren, take this money, take a year off, and visit all these 17 cystic fibrosis centers in the country. And just write down what you see. Write down what you learn. And he came back and he said, friends, chaos, chaos, chaos. Variation, variation, variation. They all do things differently. What I see is dedicated, passionate people working like crazy to get these children healthy. But in fact, there is no standard what they do. Some are obviously good in the airway cleaning. Others are good in the nutrition. But no one is good in everything. That's so shocking. We have to do something. And so the Cystic Fibrosis Foundation started in the 60s a registry. They asked all the cystic fibrosis centers in the country to report to them outcome data, survival rates, lung function, nutrition, all these things. But can you imagine what happened? 40 years, these data were not acknowledged. So at the end of the year, they sent these data to the centers back and said, well, your mortality is X, your ventilation improvement is that, but they never compared. There was no learning. And that stayed for decades. And of course, because medical care was improving, new antibiotics, surgical treatment, everything was getting better. So everyone was happy. But in the year 2002, a very interesting thing happened in another place, in Cincinnati Children's Hospital. Definitely one of the most prestigious children's hospitals in the world. They were proud to run one of the most successful cystic fibrosis programs. And when they received a quality improvement grant from the Robert Wood Johnson Foundation, they picked the cystic fibrosis program for care improvement. And to be very honest, these guys volunteered because they believed to be the best in the country. They actually wanted to use this program to demonstrate, to show how good they are. And when they asked the Cystic Fibrosis Foundation for data and for comparative data, where do we stand compared to the others, they got the feedback, you are in the last quintile. That was a big shock for a really, really well-established and highly esteemed organization. And if you hear the details, how shocked the team was, how desperate people were, how they struggled with telling that the patient and the parents, they were really anxious to lose everything, their brand, their credibility. They finally did, and they started an amazing thing. They were starting to visit all the other centers in the US, particularly the leading 5 centers. And by the way, the guy who was leading the best center by then was Warren Warwick. He had obviously learned so much in this year that he was basically mimicking all these success models in his center. So they did that. They asked for more help from the foundation. They established a web-based portal. So at 2003, every center in the US was able to put in patient-related data into one common platform. And just another 3 years later, they decided to make these data public. Since 2006, in cystic fibrosis, every patient, every physician, every parent has access to outcome data in the US. And everybody knows where he stands compared to the others. And that has created a community of learning and improving that is just amazing. And look what happened with the Cincinnati Children's Hospital. The green line shows you how they improved in terms of their lung function, and we have similar curves for other outcomes. And you see how they started from a very bad position. This here is a line of the average US centers, and you see that they ended up very close to the top. And if you look on a larger level what happened with life expectancy in cystic fibrosis in the US, you see that over the years, all the centers improved. This is an average rate. And now we have an average survival of nearly 40 years in the whole US. And you see that between 2000 and 2010, there was a major leap happening because of the transparency of outcome data. And what I like most is how over time outcome measures have evolved. At the beginning, they were measuring other things than today. And today, and this is my favorite, one of the outcomes they measure is the number of pregnancies. So a disease that necessarily ended in early childhood is now a disease that turned into something where patients can have children. And they have children. I think this is a wonderful story that has encouraged us at Ichom to work on the problem of variations. And of course, we are not focusing on cystic fibrosis. We have picked 4 different medical conditions: coronary artery disease, low back pain, localized prostate cancer, and cataract. So obviously 4 very important medical diseases, very frequent, with a high impact on costs and on suffering. And this is the starting point, and we are going to talk about that later today. We believe that we need a new definition of success in healthcare. We believe in a system where physicians create data and receive data, how they have improved patient lives. And we believe in a system where patients are able to express their expectations and where they get access to the data to take decisions. I started my little talk with variations. And I will end it with variations, because I have a wonderful group of people here who are coming from 5 different continents and from more than 20 countries. I know that in your places, wherever you come from, you do a lot of things tremendously good. And there is a chance for all of us to learn. I enjoy having all of you here, and I enjoy the variation of the day. Thank you very much. And now I would like to introduce our first speaker. Our first speaker is Beth Daly. Beth is an outstanding woman, and I have to explain a little bit her background. Beth is trained as a razor blade sharp analyst, as a financial analyst in Wall Street, as a business consultant, as McKinsey, and as a teacher and professor at DePaul. But she is at the same time a passionate and caring mother of 3 wonderful kids. And Beth has had in her life a quite horrifying experience with the healthcare system. But she has used her particular abilities to try to influence healthcare systems in a way to improve outcomes for children. So we are very happy having you here, Beth, and the stage is yours.
Good morning. You guys are quite an impressive group. I'm a little nervous talking to you, but I'm really honored to be here, and I'm honored to share my story with you. It's a 2-part story. The first part is about harm, and the second part is about my search for a good outcome. So I would love for you to go on a journey with me to my life 10 years ago. I'll show you a picture of where we live, oh, sorry, there we go. So 10 years ago, here I am with my daughter Caroline, who's 18 months old, and there's my husband Scott. I was 9 months pregnant, and we had just bought our first house. We moved out of our apartment 3 weeks before, and we were so excited to start this next phase of our life with our baby due any day. So we took our daughter on one of those beautiful fall days in Chicago to Lincoln Park Zoo. And while we're walking through the zoo, I start feeling some kicking. Now, we all have kicking in 9 months into pregnancy, but I started feeling some really strong kicking. And then about 10 minutes later, again, and this was so strong I had to hold the stroller and kind of bear down and not move through it. So as you might suspect, I was in labor. And as the course of the night went on, about 5 hours later, my contractions were 5 minutes apart, and we called the doctor, and she said to come on over to the hospital. So we went to the hospital, major hospital system in Chicago. They put me on monitors for the first hour, and I had contractions 3 minutes apart, and I was 2 centimeters dilated. After that first hour, they said, well, you know, you're really not dilating more, you're not progressing, so why don't we take you off the monitors and we'll do a walking therapy. So they told me to walk the floor and try to dilate more. Now, I didn't know at the time I was what's called a VBAC, a vaginal birth after cesarean. And I didn't know at the time that the hospital was not in compliance with the American College of Obstetrics and Gynecology, that all VBACs should be continuously monitored. So I did what I was told by the doctors. I started walking the floor. Now, after about a half hour, the pain was excruciating and didn't let up between contractions. So I literally almost crawled back to the bed and lied in a fetal position. And I actually threw something at my husband to tell him to go out to the nurse's station to get me a C-section right now. So he went out, and they said, oh, she just doesn't know how painful labor is. It's really painful. And then he went out again, because I kept yelling at him, and again and again. And then about an hour and a half later, they came in and they said, you know, you're just not in labor. We're going to send you home. I know, yeah. If I only knew then what I know now. So I said, home? I'm in labor. I can't move. This is so painful. I can't even function. And they said, no, you know, it's a really busy Saturday night. We need to free up some beds. And so we're going to send you home. And I completely freaked out. And, you know, I'm not a doctor. I'm, you know, a business person. And so I don't, you know, it's hard to argue with doctors when they're telling you you're not in labor and you're saying I'm in labor. But so the compromise was they sent me up to an antepartum, postpartum floor, and they gave me a tremendous amount of morphine for the pain. Well, not surprisingly, 10 minutes after going up to this antepartum floor, I started to bleed everywhere vaginally and vomit and got very, very weak. So they paged the doctors, and they paged them again, page number 2, and they paged them again, page number 3, And they paged him again, page number 4. And finally, 35 minutes, page number 5, they answered. And the hospital at the time didn't have a redundant paging system where if someone doesn't answer a page, it gets bumped over to the next person or elevated to the attending. So they immediately realized that I was having what you all, I'm sure since you're all doctors here, recognized I was having a massive uterine rupture. They rushed me into the OR, and when they opened me up, my beautifully, perfectly healthy 9-pound, 12-ounce baby boy was floating in my abdominal cavity. And so when I woke up from my post-anesthesia fog, it was very surreal. You know, I looked around the NICU, and my child was so big. I mean, he was 9 pounds, 12 ounces. He looked like he could get up and walk right out. And everybody else was Lilliputian. They were these little babies, and we just didn't look like we fit in there. And so it was so clear that a lot of things had really gone wrong. And you know, you're all familiar with the Swiss cheese model of accident causation, and this was the classic example of all the holes lining up in the Swiss cheese. There were so many things that could have been done differently, and no one was trying to hurt me or hurt my child, but the care just didn't line up. There were so many things that could have been changed. So when we talk about here at Ichom patient outcomes, one of the things that I am so proud of is that we talk about the good outcomes, but we also talk about the harm and the bad outcomes, because ultimately both are part of the total patient outcome. So it's very important to me as a patient advocate that when you come up with your total patient outcome metrics, that you include harm and safety and quality as part of those, because you know that's part of your experience. If you can't just count the good, if you don't count the things that didn't work out so well. So this is my son, Michael, and this is what harm looks like to me. Sorry. So we eventually took our son off life support. You know, he was very severely brain damaged. The NICU staff was wonderful in helping us to love him and change his clothes and introduce him to our family. But after we buried our son, I wrote 2 letters when I got home from the cemetery. One letter was to the NICU staff to thank them, and the other letter was to the head of obstetrics, asking him what policies could we change, what things can we retrain, what procedures need to be altered, and I really wanted to sit down to make sure this didn't happen to any other family. So, you know, this was back in 2003 when many hospital systems were in the deny and defend mode. A lot of hospital systems have evolved beyond that and recognize that transparency is not only the right thing to do, but it's frankly way more cost effective. The hospital system where I was not there yet. I'm proud to say they are more so now, and I work with them quite a bit. So I sat down with the head of obstetrics and heard the things that you never want to hear, that you know, well, we don't know why God needed your baby more than you. Saturday night's a really bad night to have a baby. It's very busy. And sometimes bad things just happen. So they couldn't take a step back and really think about how to improve the processes to make things better. So that was really disappointing. I'm glad that there are other people like Sorrel King who have had a different experience, that when they went to the hospital system had the courage to try to work with them to make things better. My hospital system where our event happened, where my son died, wasn't there yet. So I began to think, you know, how could this be different? I grew up in a crazy Chicago Irish family. You have one of those in Boston. We're like the real poor version of that. So my grandpa was mayor of Chicago for 21 years. My Uncle Rich was mayor. My Uncle Bill was in the Clinton and Obama administrations. So the Daley family have been a long time, you know, I've grown up thinking about how to make the world better and how to do better with the talents that we've been given. And so I sat there thinking, geez, if this is happening to me, it's happening to everybody, right? I can't get good care in Chicago, but we have to do something about it. Not everybody has the abilities to do something about this, and I did. So I really started to think about, you know, okay, what would change look like? What would a better set of metrics to track harm look like? What would better oversight by a board of directors look like in tracking those metrics? So I started to ask myself these questions in order to think about what my journey in advocacy and safety and quality looked like. And you know, this was a time of great change in the world of medicine. You know, the Ichom report and Don Berwick and, you know, King and Sue Sheridan and all these really great leaders were elevating the discussion around safety and quality. And I was excited to be part of that movement. But then I got this curveball. And this is the second part of my story. So I got pregnant again, which was not a small feat because, you know, there's so much scar tissue after a massive uterine rupture. They weren't sure that I could get pregnant, that there was any viable tissue in order for an egg to implant. So, you know, I got pregnant and was so excited about my journey in safety and quality and leadership and this, you know, new baby that we were about to have. And I go in for my 20-week ultrasound. I remember I was kind of nervous, not surprisingly. Didn't really trust the whole healthcare system. And I remember my husband saying the night before the ultrasound, he said, honey, we have been through the worst. It just doesn't get worse than what we've been through. So, you know, what are the chances that lightning strikes twice? Like, did he really need to say that? Note to the husband, don't say that. That's a bad choice of words. So he said that, and I go in for the 20-week ultrasound. I actually brought my dad in because my husband was traveling. My dad had never been to one. He was real excited. And so we're sitting there, and you know, they're taking a lot of pictures. And then someone else comes in, another technician. And they're taking a really long time. And we've all been in that room where you know they're taking too many pictures, and you know it's taking too long. And you get this sort of foreboding, dark sense. And then the head echocardiographer comes in and says, Beth, I'm really sorry to tell you, but your baby in utero, your baby has tetralogy of Fallot, which is a cardiac defect. It's a pretty complicated 4-part heart defect. She then goes on to explain to me that this is going to necessitate multiple open heart surgeries, and it is often accompanied by a number of other genetic anomalies. So lightning strikes twice, right? And I know I don't need to explain tetralogy to you because you're all doctors, and my version of explaining tetralogy would be extraordinarily rudimentary, but it's a 4-part heart defect. And there's the quick explanation up on the slide. So I started to think, I've been burned in this healthcare system really, really badly, and I am damn sure I'm not going to get burned again. I am going to get a good outcome for my child. So I started to ask myself, what are the drivers of a good outcome for tetralogy? Are there variations in how tetralogy is approached and how it's repaired? Do these variations exist by surgeon or by institution? And then, you know, I'm kind of a McKinsey data person, so I said, okay, well, how do I build my rubric? How do I collect the data that I think I need to drive a decision for my child's tetralogy care? So I start to build this rubric. And here's my, you know, this is just a sample of some of the stuff that I started to ask. And for those of you that are cardiac people, I want to remind you that, you know, I didn't even like biology in high school. So, you know, I am not a medical person. I know this is rudimentary for the cardiologists and cardiac surgeons in the crowd. But I was 6 months pregnant, and I was trying to do the best I can to come up with a good outcome. Because as you know, the data wasn't out there. So I started to ask myself, okay, well, obviously, mortality rate. I don't want my child to die. I want to look at the volume, because I started to read in the literature that volume mattered and experience mattered in terms of outcomes. I also wanted to look at tetralogy surgeries that are valve sparing, because I heard about this innovation that I read about in some of the journals. And I was lucky because I had access to those journals, because at the time I was a professor at DePaul, so I could go run a LexisNexis search and access the stuff that you all access. But the average person can't access those journals. So I started reading all these journals and reading the footnotes and learning about these innovations. And there actually was a really big innovation that a lot of the institutions in the country were doing the surgeries for tetralogy the old-fashioned way. And my rudimentary explanation is that, you know, with the 4-part heart defect, the big piece was the pulmonary valve was too narrow. And the old way of fixing it is they would cut that pulmonary valve, and they would stretch it, and they would put a little patch, kind of like a piece of Gore-Tex, but it was called a transannular patch over that valve. Now, as the child grows over time, that patch doesn't grow with them. So tetralogy kids typically get a leaky valve. And that's what necessitates the next open heart surgery. So they go in, they put a bigger patch, and then they get a couple more years, and then they go in and they put a bigger patch. And usually after the 4th surgery, by the age of 10, the tetralogy kids have the valve that will work for their adult heart. So there's a new way of doing this. And that involved incredible amount of coordination. You had to involve the cardiac catheter team, the interventional catheterization team, and they would stretch the valve instead of cutting it while the surgeon worked on it. Now, this was a really big innovation, because if you stretch the valve and never have to cut it, you don't get leaky valve over time. And there are all sorts of bad things associated with leaky valve. You know, first of all, 4 open heart surgeries versus 1. 4 versus 1. That in itself was a massive difference in outcome to me as a parent. Secondly, I began to read in the literature that a lot of the kids who are on heart-lung bypass 4 times have a high prevalence of ADHD. They also tend to have more altitude restrictions, and they also you know, have some other physical problems, like they can't be have more exercise restrictions. So my husband's a skier. We're like, maybe we can not ski for the rest of our lives. Oh, let's see if we can cut out altitude restrictions, cut out exercise restrictions, cut out ADHD, and try to get this valve sparing repair. So we really, you know, thought for ourselves, if there's any way to get this outcome, we want to try to get it. So now I needed to get the data. So I developed my rubric. I said, okay, this is the data I think I want to get, right? I want to ask these questions. And then I tried to search for it, and it's nowhere. You can't get it. I can find out more about the safety of my car, the price of my car, all the different, you know, fuel mileage about my car. I can find out more about the mutual fund I buy and the 5-year returns on my mutual fund and the fees than I can about buying my son a cardiac surgery. I can't get the data. So, you know, going back to this, I'm not going to get burned by this system. I just didn't trust everyone. So then I started to get on airplanes, 6 months pregnant. And I flew around to 7 different pediatric cardiac centers to meet with their top cardiac surgeon. The way I kind of figured out who to meet with was I looked in the footnotes, and I figured that whoever was doing research and writing a lot about this probably really cared about it. You know, and not the most scientific way to drill down to, you know, but I was pregnant and the data's not out there, so I'm doing the best I can do, right? I'm just trying to get my son a good outcome. So some of these surgeons were very welcoming. They sat right down with us. Others, you know, it was laughing, you can't meet with our surgeon. And so we then said, we're going to figure out how to. And we reached out to everyone in our networks, from my husband who went to school here, and I went to Georgetown. We started calling everyone. Can you get us into this surgeon? And so we met with these 7 surgeons, and I built my complete data set. How many tetralogy surgeries does your institution do? How many total cardiac surgeries does your institution do? How many tetralogy surgeries and total cardiac surgeries do you personally do? I would ask the surgeons. And then I would ask them what % were valve sparing and what % of their outcomes had altitude and exercise restrictions. Now, I know this isn't the comprehensive list of everything you'd want to ask, but where I was standing at that time, this was the best I could do. So I built my data set, and I want to show you just a very small example of some of the results that I found. So let's just take 3 hospitals, Hospital A, B, and C. Hospital A had 12% of the total tetralogy of the surgeon's total tetralogy that were valve sparing. Hospital C, 60% of all their tetralogy was valve sparing. That's a vast difference. Like, if I go to Hospital C, I have a way better chance of getting my son a valve sparing repair. Similar huge differences of altitude and exercise restrictions. So I did this for all 7 hospitals. I know there were a lot of hospitals that I just didn't have time to get to or couldn't get access to. But, you know, as they say in the OB business, my, oven was cooking, and I had kind of an endpoint here. So tetralogy, I thought, this is it. I've got a plan. I found the cardiac surgeon who this is gonna give my child the best chance. But I didn't just care about tetralogy, because all of a sudden, 4 weeks later, I got a diagnosis of a tracheoesophageal fistula. Curveball number 2, lightning. So for those of you that are in the esophageal world, a tracheoesophageal fistula is when this is my rudimentary description, so bear with me. It's when the esophagus grows in 2 parts, and the bottom part grows into the trachea. There are a lot of different variations of esophageal atresia and tracheoesophageal fistula. Ours was a very severe case. It was called a long gap tracheoesophageal fistula. So this threw a whole nother curveball into my outcome grid, because I had a plan for tetralogy. But this now said, I need a general surgeon, and I need a really good high-risk OB, because tracheoesophageal fistula is often also accompanied by very complicated issues in the pregnancy, in particular something called polyhydramnios, where you get too much fluid in your belly because the baby's supposed to swallow the amniotic fluid, but if that esophagus pipe isn't connected, they can't swallow it, and the balloon gets a little too big. So now I wasn't just searching for a cardiac surgeon, I was searching for a very high-level NICU, an anesthesiologist that's there and ready to go, a very on-the-ball high-risk OB, and a general surgeon who had experience with tracheoesophageal fistula. So we then spread these questions, and I built my TEF outcome grid. So these, also I'm sure this is rudimentary to you, but remember, I'm doing this under a pretty intense time frame. So these are some of the questions that I asked, like total number of surgeries, % of total surgeries that are TEF, EA. Are they connected to a high-risk OBGYN facility? Do they have on-site anesthesia, a level 3 NICU? And then I asked what I viewed as kind of the outcome that I was trying to drive towards. Will my child be tube-fed at age 5? Will my child with TEF have exercise restrictions? Because a lot of the TEF kids that I read about on the parent portals, they had a lot of pulmonary issues. So those were the TEF questions that I asked. But knowing that I had been burned in the system, I didn't just ask TEF questions or tetralogy questions. I also asked safety questions to all these surgeons and doctors that I met with. I wanted to know, if bad things happen, how does your institution deal with it? What's your approach to apology and disclosure? I wanted to get a feel for their total surgical site infections, and even just asking the question, if they didn't have the data, really gave you a sense for how they approached it. I wanted to know things like I had read about a surgeon timeout. And I wanted to know, did you do a surgeon timeout at the beginning of your surgery? And I asked about your hospital-acquired infection rate. I also asked about things like a just culture. I kind of created my own Harvey ball system that talked about whether or not I felt like there was open communication with the patients. And last, I talked to each doctor about oversight of residents and fellows and ownership of the patient. So I wanted to make sure that if I went through all this work to figure out which surgeon was doing that cardiac surgery, that they weren't having that resident run the OR. So this is a windy winter day in Boston for us when my son was born. And he was born a couple weeks early because of the polyhydramnios. And this is what he looked like after his 7-hour tracheoesophageal surgery upon birth. It wasn't all a walk in the park. He got a beautiful valve sparing repair. This is after you can see he came out with an open sternum after his tetralogy repair. It was 3 months in the NICU for us. We never could leave in between the time that we got our tracheoesophageal repair and our tetralogy repair, because his heart rate and oxygen levels could never quite get stable. So those stats we were ringing alarms the whole time in the NICU. But then after his tetralogy repair, we were able to go home. And I want to just pause for a second here, because just focusing on the valve sparing repair, it takes a whole system to deliver good care. And even if you give a great valve sparing repair, that repair doesn't matter if there's harm and other things go wrong. So in our 3-month stay in the NICU, we contracted VRE, which is a hospital-acquired infection, and we went into isolation for a month and a half, which is really hard for a family to be in isolation. And he got overdosed the day I took this picture while he was on a ventilator. And they were able to reverse the course. There was no long-term harm. But it takes an entire system to give good care. So when we think about the totality of patient outcomes, all those pieces matter. It matters to search for good. It matters to address harm. And they all have to be put into the long-term picture. So this is us when we came home from the hospital. And I want to just quickly fast forward up to today, because this was 5 years ago. So there's my other 2 kids and my little guy, Mac. He's had a very rough road over the last 5 years. He's had 26 esophageal dilatations to stretch his esophagus. He also had some vertebral and spinal issues. He had tethered cord surgery, which went great. He did have a lot of feeding challenges because of too narrow esophagus and frequent pneumonias. So he has a G tube and a J tube. He typically has gotten about 4 to 6 pneumonias a year. We've gotten much better at managing that through a very aggressive pulmonary regimen. He did get Pseudomonas, and he's in a lot of feeding therapy. So here he is with 1 pneumonia. There are his feeding tubes. So, and this is him today. And he is great. He is 5½. He plays the violin and the piano. Our focus on a good outcome means he has no altitude or exercise restrictions. He skied with us all last year at Breckenridge and Vail last winter. Our focus on the feeding kept his brain developmentally in track. So, he has a violin concert December 6th, if anyone's in northern Wisconsin wants to come. So it's thank you. So it's a successful outcome, but it's not all the way there. He still has a very, very, very rough road. And so I just want to go to my closing thoughts. I feel so honored that the Ichom group asked me to share my story, because it's this 2-part story about the most horrific harm that any parent has to experience. And it's also a story about the search for good. And I think that's what you're marrying here today. How do we define good outcomes and make sure that we also include harm as part of that total outcome? And how do we look at that outcome from the patient's perspective? Because, if you just measure mortality rate, that doesn't look at the full picture of what I was trying to achieve for my son, how I defined a good outcome. So I would just like to say that my passion for transparency, it hasn't ended at the bedside. I serve on the board of 2 major hospital systems, of Theta Care in Northeast Wisconsin, a 5-hospital lean hospital system, and one of the 32 Pioneer ACOs, and on the board of Children's Hospital of Wisconsin in Milwaukee. I think what you're doing here at Ichom brings such great value to the boards as well. You know, boards want to know that we're delivering a good product, and having patient-centered outcomes, that's answering the most important question that boards should be asking. The day I got pregnant, or not the day I got pregnant, I won't go there. Oops, excuse me. So the day I went into labor, let's start there. The day I went into labor, when we were at Lincoln Park Zoo, I was walking with my daughter and my husband, and there was an exhibit right by the giraffes, and there was a quote by anthropologist Margaret Mead. And when I was thinking about what I wanted to say today, it was going back to that day that I went into labor when we were at the zoo, and I kept thinking about this quote. So she said, "Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. And to me, you are that small group that is changing the world of outcomes for patients like my son. You are bringing that transparency. You are bringing that accessibility. And I'm very grateful. And I think when you achieve what you're doing, there'll be a lot of patients like my children that will be very grateful. Thank you."
Now I want to introduce the next speaker. And you know, when you had asked me for my personal ranking of great thinkers in system change in healthcare, Tom Lee would be very, very high on this list. And actually, I knew him long before he knew me, because I read his books, I read his articles regularly in the New England Journal of Medicine, where he reflects about what's going wrong in our healthcare systems, how can we improve. Tom is trained as a cardiologist and internist, and he was a professor for medicine in the Harvard system at Harvard Medical School and the Harvard School of Public Health. Tom was leading as a CEO the network system of primary care of Partners Healthcare here in Boston. And he did a bold step just recently, because he changed from this academic medical position that he left for decades into a totally new position. He's now Chief Medical Officer of Press Ganey, the leading organization in the States in patient surveys, because he believes that collecting data and collecting meaningful data will have the highest impact on system change. Tom, great having you here, and we're really looking forward to listening to your talk. Thanks.
Thanks very much. And I want to say that I thought Beth's talk was fabulous, and the quote that I was thinking of at the end was actually, I'm paraphrasing the quote from Nietzsche, which I'm sure many of us know, which is that if you have clarity on the why, you can endure almost any how. And so her story is the why. Why we're really in this business. Now, what Jens wanted me to talk about are some of the issues around the outcomes work. I mean, we are not here to just define the minimum set of boxes that need to be checked off. That's not our goal. Our goal is to make care better. And so what I want to talk about from my experience as a physician, as someone trying to work with my colleagues at Partners Healthcare, as someone looking around the country a bit more and trying to help create a performance framework, are the issues around how do we collect the data, how do we report it back, and then what do we do with the data to actually try to drive real improvement. And these, of course, are big, complicated issues. They're hugely important, and that's why this work is part of the work of those things. The reason that it's so timely is I think we all recognize we are at this moment of discontinuity in healthcare in every system in the world. The discussion is usually about money because we can measure money, but we know it can't only be about money. And the real challenges, as I think Beth's story shows, are also driven by the fact that we've had this tremendous progress, and it's led to wonderful things, but it's created this tremendous complexity. We have so many people involved, and there's chaos, and we don't work together. We disappoint. We don't patients all the time, even as we do work very, very hard and do wonderful things. My friend and colleague Atul Gawande has been saying lately, the last century was the highest value was autonomy, and that was okay when medicine was simpler, when we didn't know that much, when there wasn't that much to do, when there wasn't anything you could do for tetralogy, for flow. That was, the 50s, and Helen Taussig and Alfred Blaylock at Hopkins, who first came up with an operation would do anything for tetralogy of flow. I think that now, though, it's a very different story, and what Atul was saying is that this is a century of systems. Actually trying to figure out how are people working together, what are they producing as they work together, and then trying to help them get better. And so, that's what is the results of our systems, good and bad. That is the real work that brings so many of us here today. Now, I have about 10 slides. This is a figure that was from the online blog that Mike Porter and I wrote that's accompanying, that complemented our article that's in Harvard Business Review. But this was an article. This was a sidebar blog that's called, why we on the HBR New England Journal collaboration website that was called, why we get stuck in healthcare. And I can tell you that. I should have a PhD in what does not work in healthcare. I believe me, I don't come and follow me around to see magnificent success stories. And the point we wanted to make is that there's a reason we've been stuck. Why it's been so hard to get things done, and it's intertwined, mutually reinforced factors. Healthcare being organized around what clinicians do as opposed to what patients need. Measurements of processes and revenue and not revenue on what's actually happening to patients and what they care about. A payment system and so an organizational structure that reinforces that. That's familiar to everyone. I don't need to talk about it. The article that Mike and I wrote, believe me, Mike, I think we all know Mike has been teaching this framework for several years before, Jens and I met going to a course, and we sat next to each other in a course where Mike was already talking about this framework. So, I can write and I have some clinical context for things, but, this is Mike's framework, which I think you're all familiar with. The key things which we want to emphasize is that, these factors are not, this isn't a menu where you just pick which of these things is least miserable for you and say, well, you're doing something. That, they're mutually reinforcing, intertwined factors, and if you are pursuing them together, you're going to get more return on your investment. And what we're talking about here today, here at Ichom, is part of number 2, measuring outcomes that matter to patients. And the thing I want to emphasize is that what we're talking about in Ichom is a part of a part, of a framework. So there's a lot of work to be done. If you look at these outcome measures and you're not quite sure how is the world going to change because of this, is because they're not. You can't think about them in isolation. It is part of a part. Now that said, I think we actually are figuring out what all the parts are and how they fit together. And I'm very optimistic that things are that we're on the way, that things are getting much better. And I was thinking about when Beth was telling me that horrible story about the responsiveness when she was in crisis. I was thinking about Advocate Healthcare in Chicago, where they now have banned meetings between 8 and 9 every morning. They have meeting-free zones, and that's so that every part of their system can have a safety huddle. Nothing should come before that. And after they did that, they just began this spring, and after they did it for a couple of months, actually a few months, they got to the July 4th weekend, and they realized they were looking at a 4-day stretch without any patient safety huddles. The staff actually said, we have to do this 7 days a week. We can't do this 5 days a week. So, the culture is changing, and we are making progress, but, it's hard. Now, I made my move because I think that data is powerful, but one of the things I'm going to say is, anyone who does something knows the limitations of what it is. Echocardiographers know the limitations of what echo can tell you. I'm a believer in collecting data. But I'll say a little bit about some of the things that need to complement it. I think that, I actually, when I first started talking to Press Ganey, one of the first things I did was have a long talk with Mike, and I actually, had to talk about patient experience and patient satisfaction. Many of you have heard him make not completely positive comments about it, in his course. And so what we discussed is that it's changing, and there's been traditional skepticism. It's flavor of the month, it's hotel things, it's Disney stuff, and healthcare is not an amusement park. It's something different. It's a threat to professionalism, having patients actually judge doctors and what they're doing. But those things are in the past. I'm saying they're in the past. I'm hoping they're in the past. But what's changing is, what's being measured. And it's very clear from people who have looked at the data that the drivers of likelihood to recommend, what seems to be what causes patients to want to recommend a hospital or a doctor, food, parking, they don't matter. Food and parking matter to people when they're eating, when they're parking. But after that, they're usually not doing those things, and that's not what they come to the hospital or to the doctor for. There are other things, and the kinds of things which statistically are overwhelmingly the big drivers are, their confidence in their caregiver, usually the doctor, but there are other clinicians as well, how coordinated they feel that their care is. And that is increasingly an increasingly important factor because patients are smart. They know that care is complicated, and they are worrying about fragmentation of their care. They are actually they're one of the outcomes that we realize, my colleagues and I realize that is important is, do people feel trust? Do they have peace of mind? Do they feel confidence? Or are they worrying, like Beth, that lightning might hit again? So actually, coordinating the care and then showing that the care is coordinated, that's actually a major driver. And how clear is it that you're interested in what's happening to the patient, what they're worried about, And there are ways to actually improve on these things that are increasingly clear as well. So what's important, what's being measured is changing. I'm going to talk a little bit more about that in a second. How much data are being collected? That has changed as well. Now, Mike, should have the satisfaction because he's been saying, as long as I've known him, is that we should be measuring the outcomes that matter to patients on every patient. Well, that's where things are going, now. Like in the last year, electronic surveying has become, routine, at least, for my organization, new organization offers it, and many others do as increasingly, so that, they call it census-based surveying, where it's not a sample of patients at the end of, a quarter or something like that, but it's every patient. So that, my wife is head of medicine at Harvard University Health Services, a mile from here. So every patient, after every visit, gets an electronic survey sent to them. They don't all respond. It varies by types of patient and so on. But they end up getting 50% of the surveys back in 24 hours. And they end up being able to give physicians feedback not on 15 patients, but on 200, 300 patients. And it changes the game. And it changes the way that the data are being used. They're being used for improvement. They're being used for the care of individual patients. And what patients are going through is actually on its way to becoming like a vital sign, like the blood pressure, like the temperature. It's a transition that's, and it's going to change even more in the next 3 to 5 years. What my colleagues know is that the business will be one where you collect data across the continuum of care, and you collect PROMS data as well as some of the traditional patient experience data. I had at least 8 emails just in the last 24 hours about PROMS, and the next phase and how we pursue that strategy. Now, one of the things that led me, now let me talk about now how we present the data back to people, because one of my friends, the chief medical officer at one of the teaching hospitals, not far away, said, what they get now are numbers that numb, and that doesn't drive improvement. And so when I met the CEO of the new organization that I now work for in March, he startled me because he said that I was saying how we're trying to become more efficient, but there is this question about efficient at what? If you don't have an idea of what you're trying to accomplish, trying to become efficient feels like you're just seeing where can you get away with cuts without precipitating too much of a riot. And so he said, well, we've thought about that, and what we're trying to do is we feel like our business strategy can't just be doing surveys. We have to have another strategy, and that's helping organizations be successful by helping them reduce the suffering of their patients. And I was kind of startled, and I wrote a piece in the New England Journal, which I know some of you read a couple weeks ago about, it was called The Word That Shall Not Be Spoken, because my reaction was, well, that's what we try to do, working at Partners Healthcare. But I didn't like the word suffering. I was taken aback because I said, it seems kind of emotional, it seems kind of sensational. And I couldn't remember the last time that we used the word suffering in my work at Partners Healthcare, even though we're good people working really hard. And then I went from there to a New England Journal editors meeting, and I was talking to one of the copy editors about that, and she goes, well, we don't use the word suffering in the journal. I said, we don't. And she said, yeah, there's a policy. If the word suffering is in the journal, it means a copy editor made a mistake. And then she showed me the AMA style guide, which is what most of the journals use. And the style guide says, I quoted in the article I wrote a couple weeks ago, don't use overly emotional terms like suffering. And so that led me to be, okay, why do we not use this word? Because it's so clearly, I didn't like the word, but then I thought, it is what people are going through. How can you come up with an argument for not using it? And then, I talked to colleagues, and the answer I got back, I got good answers back, but like one of them, the most common was, it makes us feel bad. It makes us feel guilty. It makes, we don't want to think of ourselves the kind of people who would stand by while people suffer. And I'm not arguing that Ichom should change the O to an S, but I actually think that organizations like Press Ganey, people in management roles, should be shining the light on the data that we collect and calling it what it is, because it demands a response in the way that some other terms that we might use might not. I mean, just this week, a physician leader from an organization said to me, please don't call it suffering. And I go, why not? And he goes, I don't know, but please don't do it. And so I said, that's why we're going to do it. And so, all right, so and this preceded me. I actually think that Martin made me extremely happy last night when he said he thought that this terminology might change the game in healthcare. And you shouldn't give credit to me, if we're successful. This preceded me, but like it's fleshed out. It's being fleshed out further, into suffering from diagnosis, suffering from treatment, suffering from the dysfunction of the delivery system. Not the same as Mike's tier 1, tier 2, tier 3, but like very, very resonant with it. With the goals being to anticipate, detect, mitigate the unavoidable suffering that goes with disease and treatment, because there is going to be suffering in healthcare. But then we should do our best to understand it, bear witness to it, relieve it. And then to try to prevent the suffering, the anxiety, the confusion, the chaos that we all know about, the lack of trust, that poor Beth went through after her first terrible story. So we're beginning the work. We're taking the measures that exist now and begin to break them down and preparing report card frameworks that get at how much people are suffering and getting ready to feed it back. In that way, from the different types of suffering. And there are things that we have that like trust that I think that I hope people understand that is an outcome. how much trust or lack of trust people feel. There are things which we don't have, which we know we want to try to get to, like how much fear people have as they go through care, how much anxiety that they have as they go through care. So these are things that, you know, I'm excited about this work. But now, how are we going to use it? And the last few slides I want to show relate to, you know, my work with my colleagues on the provider side, and then I had a wonderful Harkness fellow, an ethicist from Zurich, named who's, you know, good friends with Jens as well, named Nicola Biller-Andorno, who wrote a paper with me in March in the New England Journal called From Sticks to Carrots: Ethical and Effective Incentives, something along those lines. And working with her, I learned about this framework, which I actually think is pretty useful. And Max Weber's 4 models of social action. And for those of you who are real social scientists, you'll know that this is a slightly popularized version of Max Weber's 4 models, but I think it's useful in that Weber was not interested in healthcare. He was not interested in, you know, touchy-feely things. He was interested in how do you get people to do things? How do you get soldiers to charge into battle and that kind of thing? And so he wrote about 4 models: tradition, self-interest, affection, and shared purpose. You know, where I'm going with this is that you need to press every lever. You know, one of the economists, Richard Frank, who's a friend of mine, you know, we were talking about this, and he said, "Oh yeah, this is like Jan Tinbergen's macroeconomics work that won the Nobel Prize on targets and instruments, which is for every target you have, you need an instrument. You know, you can't expect multiple things to do multiple things, and one thing to do multiple things. So we need to press all of these levers to produce change in healthcare. So tradition, you know." The example I gave is the Mayo Clinic dress code. You know, they have a dress code there where men are supposed to wear ties, including when they're going back and forth from work. And women are, you know, you can't wear pants. You have to wear something with a hemline, and it can't be more than 2 inches above or below the knee. And you have to wear hosiery, even no matter what the temperature is, even if you're in Mayo, Arizona, and it's 110 degrees. But it goes with some other good things where, like, you know, if you get a beep, the second kind of beep on their beeper that's a clinician calling a clinician, you respond immediately. You don't have 4 beeps, you know, and there is, you know, in tradition, the incentive is you don't want to be thrown out from the group. And you know, there is this implied message at Mayo that if you don't answer your beep, we will put you out in the winter and you will die in the cold, which won't take long. You know, then the second kind of model is self-interest, you know, with performance bonuses. And they're, you know, they get people's attention, but, you know, they've got their limitations. You know, you can only reward so many things, and people always go, well, you know, if you carry this to extreme, you know, we'll be ignoring everything else and that kind of thing. Affection, very powerful, peer pressure, you know, and no one wants to look bad in front of their colleagues. But then, you know, the most robust, not powerful, but the most robust is shared purpose, having an idea of, you know, what the overall goal that you're trying to accomplish is. That is what leads soldiers to charge into battle. I put up here reducing suffering, preventing harm, improving value. But having that discussion about what is your shared purpose, that's very important. And one of the things I've learned just in the last year is the limitations of data. I think to create shared purpose, you need narrative. You need stories like Beth's. You need a sense of that there's a we who can feel like something is absolutely intolerable, or something really gives you pride. And, you know, a big part of leadership's role is to create that sense of we, to recognize those stories when they're happening, and to be able to tell them in a way. You know, the example I give you, as many of you know, the Cleveland Clinic, they offer patients, every patient calling for an appointment, they say, would you like to be seen today? That did not come from their marketing department. That didn't come from the strategy group. That came from one case of a patient who called urology, asked for an appointment, got an appointment in 2 weeks. You know, that's what the clerk's supposed to do. And then that night was in the emergency department with acute urinary retention. That patient didn't die, didn't have a worse outcome in the traditional sense, but that patient was miserable for 3 or 4 hours, and they had a discussion in their management group at the Cleveland Clinic, and they said, can we be a group that, that doesn't even try to figure out who needs to be seen right away? And so they had that sense of we, and they just felt like this is intolerable. And then they started what started on the path, and it's turned out to be a great business success as well. So the thing that Nicola and I wrote that I really believe is you have to press all 4 levers. But the first lever that has to be pressed is that creation of shared purpose. And that is driven by narrative, is driven by cultural creation of the sense of, this is what we're in the business for. And, this is one of the reasons why I think the focus, calling suffering, suffering, I think that there's a reason to do it. Because it's not to manipulate people, but it's what our times call for, to remind people what our business is really about. And then, and because if you don't have that, in isolation, any of these other 3 things can seem perverse. And, people will try to game it. They'll come up with a reason for saying why ridiculous things will happen. But if everyone understands what the shared purpose is, I think that's necessary, but it's not sufficient. I mean, you do need these other levers to actually drive improvement. You need the data, but I think you have to begin with something else. But then, you need the data, and so peer pressure. You need individual physician-level data. We all do want to get better, even after we get done playing defense. We want to learn. We feel peer pressure. Financial incentives, do work, and experience and outcomes data increasingly are being used in compensation programs. Tradition, I'm seeing more and more organizations actually getting rid of people who just can't work with others, And one of the organizations, not partners that I'm connected to, it was just a call where they just decided we're getting rid of some guy who brought in 25 operations a month to one of the hospitals. And I said, well, I'm proud to be part of a group that's ready to give up the revenue. And they said, well, we're proud too, but we were probably spending more dealing with the headaches from this guy than we were actually making from his procedures. But you're seeing more and more organizations just say, what, we have to get rid of this person. And when they do, everyone says, what took you so long? So the stakes are high, and you need good data on metrics that really matter, and you need lots of it. And that is one major reason why the work that Ichom's doing and all of you are doing is so important. So with that, let me turn it back to Jens, and we'll move on. Thanks very much.